I'd like to welcome you to the American Psychiatric Nurses Association's Policy Forum. My name is Peggy Halter, and I'm the co-chair of the Institute for Mental Health Advocacy. During these policy forums, we will be bringing experts on board to share their knowledge and expertise and experiences in navigating policy as it pertains to psychiatric nursing and psychiatric care. Today, I have the privilege of introducing Sharon Katz, who will be presenting her knowledge about policy implications of integrated care. I'll give you a little background on Sharon. Sharon received a master's in child and adolescent psychiatric mental health nursing and a postmaster's certificate as a family psychiatric mental health nurse from the University of Pennsylvania. Sharon holds a certificate in marriage and family therapy from the Family Institute of Philadelphia. Sharon is a frequent presenter at APNA both at the state and national level. Most of her work focuses on integrated mental health models of practice, including mindful care, a new nursing model, and holistic approach to mental health care. Sharon is currently the owner of Collaborative Care, a multi-site and integrated mental health practice based in Abington, Pennsylvania. It was founded in 1995 to advance psychiatric nursing in integrated medical environments. Sharon has worked in primary care and dialysis practices as well as developed an outpatient clinical practice to provide supportive mental health services. Her current office now has 19 clinicians in 2 outpatient centers and 2 integrated offices. These offices are both family medicine and pediatric. She continues to manage a large clinical caseload that reflect chronic mental illness as well as medical comorbid conditions. I'd like to start off this policy forum just by asking Sharon to please describe the background of her interest in working in an integrated care setting. Sharon?
Thank you, Peggy, and thank you, APNA, for this privilege. Integrated mental health dates back many, many years, like 50 years, and I became very involved at the very beginning of a project that was based out of U.S. Healthcare, in which I was an integrated member of the team that was overseeing integrated clinicians, and I was working for a outpatient clinical practice. And after I went through the orientation process and the first about a year of that program, I left that program and then decided to move into doing it my way, basically focusing on the psychiatric nursing roles. But I've been following it for a very long time, being in various different conferences and understanding what models of care that are being offered in the communities throughout the country and what demonstration models are being done in cities. And the information has been dramatic, and I'm glad to see that it's progressed to this point. For many years, I found that I had to make a list of obstacles to why I can't do it, why I can't, as a commercial provider of mental health services and as a psychiatric nurse, advanced practice nurse, why I could not actually open up my own integrated mental health group in a primary care practice. And I would make lists year after year, and then each year we would be able to say, okay, legislation, various things I could cross off, and we would be able to then work on those things. Or I'd ask my professionals that I know, my colleagues, my mentors, what they thought approach would be, and that's how we progressed it to this point. The Institute of Medicine created a funded project that wanted to investigate the future of nursing, and this was an integral part to make major changes in policy formation. The integration of mental health is also very important in this document, and it really illustrated in this document how we needed to bring future opportunities to allow us to expand in utilization. The recommendations of this document focus on the scope of practice barriers for RNs and APRNs, and this would give us the opportunity to address how psychiatric mental health needs to be expanded in the community mental health centers and the community health centers and the patient-centered medical homes. We need to be able to illustrate our scope of practice, and the Future of Nursing document really focused on the barriers that we have at this point to producing best quality mental health care available. The second recommendation was to expand leadership of nurses in medical teams through collaboration and care coordination. This is essential for us to have a calling in the patient-centered medical home because primary care providers do not have a lot of time to really lead the teams or partner with us in the teams. So this gives us a role that's very significant. The next recommendation was to implement nursing residencies to expand basic education and provide supervision during transition to professional roles. This was seen more in other clinical environments and clinical roles for other types of professionals, but this is something which we really could take seriously as well as a way to teach various different skills for the new graduates of APRN programs and RN programs so that they can function more in these patient-centered medical homes and the integrated models. Another recommendation of the Future of Nursing document was for health information technology to be used in integrated healthcare settings. In integrated mental health, we absolutely need to have health information technology. This is the critical link between the medical and the psychiatric, allowing us to communicate appropriate information and not all information to the primary care team. The next recommendation was for roles of nurses to lead partnerships. And the way that I've interpreted this is that roles of psychiatric nurses to lead the partnership in primary care and develop roles with psychiatrists to demonstrate collaborative practice. And this is what I've used in my practice. Well, psychiatric advanced practice nurses do lead the teams. They do refer to the psychiatrist in my practice so that they can have a role in either collaborating with us or taking on patients that are more acute than what we feel comfortable in handling.
So in 2010, the Institute of Medicine's report came out, and at the same time, the Affordable Care Act was being rolled out by Barack Obama. What kind of influence did the Affordable Care Act have on what you were doing with integrated care?
Oh, it was tremendous. We were waiting for this for years. The recommendations from the National Council of Community Behavioral Health and other organizations had been working on the patient-centered medical home and integrated mental health models for 30 years. We needed to be able to have a voice in healthcare, and through these documents and these models, we were able to produce it, and we were able to show cost savings. By putting it into legislation, and the Affordability Care Act specifically went into pages of discussion about primary care and how primary care is poorly reimbursed. And the primary care doctors had very little incentive. They were just working their feet off and trying to keep up with the demand and the needs. And they were dealing with a lot of psychiatric care in their practice settings. And there was dramatic data that illustrated that it was not cost-effective the way that our old model was being proposed. So the ACA actually transformed primary care with incentives to demonstrate integration and collaborative care. And they chose the patient-centered medical home model, which is one of the models that was proposed, because the NCQA actually worked with that, and I'll talk about that a little bit later. But prior to the ACA, we did not have a voice. And no matter how much data came out, we could not change the system because the reimbursement system was deeply aligned to traditional reimbursement for illness, not preventative care, not for early identification, not for treatment. And it separated mental health from primary care. And it had a silo system of reimbursement. And that's slowly changing. So we're seeing that. The current healthcare system, as I said, was built on episodic care. And it failed to meet the need for prevention and earlier intervention of chronic medical and mental health disorders. The ACA also focuses us now on patient-centered care and comprehensive care and coordination of care addressing shortages to accessing care. So the patient actually is more involved. The primary care team is more diverse and allowed us to collaborate and actually gave us incentives, money incentives, to do that collaboration in the primary care setting. Unfortunately, at this point, the ACA reimburses and the NCQA, the National Council of Quality Assurance, reimburses only to the primary care medical homes, not to the mental health providers at a higher amount. So that is still an obstacle. The patient-centered medical home model, which I've referred to, actually is a little bit different, and it's very physician-focused. Okay, so when it says physician, they wanted to make sure that physicians are still the head of the team, even if they, it could be a nurse at the head of the team in a clinic model, but they wanted to put physicians at the head of the team. And I don't know what the policy implications are going to be for that word, and that's something which we can address later. But the patient-centered medical home is one of the models of healthcare delivery. But as I mentioned, the National Council of Quality Assurance actually oversees an enhancement of primary care reimbursement. And they follow 7 general characteristics. And the first one is personal physician care. That means a doctor, or in this case a doctor, actually a patient knows that their doctor can be called upon and they will see the same doctor consistently. The second one is the physician directs the medical practice. And as I said, that's something which we can always discuss in the future. The third thing is the most important piece. It's oriented towards the whole person, which means the mental health is now included in the patient-centered medical home, which is why we've really been able to expand into it. The fourth point that they look at in the NCQA characteristics is the coordination and or the integration of the care. Is this care also then, is there feedback loop? Is there a way of giving it to a handoff? And what documentation do they have going back and forth? Do patients follow through with the recommendations? And how are they handling that? The fifth general characteristic is the high quality and safety in care. And this is basically evidence-based practice. They want to make sure that the primary care homes are actually using basic logarithms that allow us to track the best care and actually give the recommendations. And that's key to their quality measures that they have, and there's 75 quality measures, which we'll discuss next, in the HEDIS measures. And the sixth general characteristic is enhanced access to care. So the primary care medical home is rewarded for accessing mental health care, and that's key to this process. And the seventh is that payment supports the enhanced services. I've yet to see that, but it does for the physicians, and it does for the patient-centered medical home. It doesn't for the outside providers coming in as much as it does for the internal bonuses that the patient-centered medical home model actually gives the primary care practices. And they do support us, and they do provide us the office space and other services, even if a lot of them do charge rent. It is something which they have as an incentive in their services, and that does come back on us in that. As I mentioned, the HEDIS is the Healthcare Effectiveness Data Information Set, and this is also included in the patient-centered medical home as a very essential piece of measurement of the performance on the dimensions of care and service. And this is a lot more transparent about what we are looking at as reimbursement. And 90% of health plans use this HEDIS tool to give us reimbursement. And I said us, it's because in many ways this is the trend of the future. It is something that's going to be phased in over the next few years for mental health. It looks like it's very active at this point. And measures for primary care doctors are right now measured for their performance in certain benchmarks for psychiatric care. They are measured in terms of whether or not they provide depression monitoring, ADHD assessment and monitoring, follow-up after psychiatric hospitalization, diabetes screening for patients with schizophrenia, and adherence to atypical antipsychotics for schizophrenic patients. Now, I am extremely excited about HEDIS in some ways because it actually opens the door for us to have an impact, have a discussion more often with the government regarding integration and how to get paid for it. And I think that by taking over some of these monitoring characteristics and developing our own, it shouldn't just be for atypical antipsychotics for schizophrenics, but for bipolar, early identification of bipolar illness, screening of adolescents for early signs and symptoms of psychiatric illness. I think that there's a lot of other measurements that we can actually instill that would put our worth back in the patient-centered medical home.
Absolutely. I think the measuring portion of what we do and finding out if indeed we are being effective in providing this primary care and integrated psychiatric care is essential to the future of what we're doing with integrated care. Sharon, as a leader and innovator in nursing in general and psychiatric nursing specifically, I'd be interested to hear your vision for integrated care as we continue.
It's important for us to understand that all the data that was collected over the past 30 years had some significant findings. It's important to understand that 80% of all psychotropic medications are prescribed by primary care providers, yet primary care providers fail to demonstrate adequate diagnostic criteria and do not advance the level of initial medication when trial is inadequate. This is a finding that dates back many years, and still they have not been able to implement further changes in this. We need to develop a healthcare plan that actually addresses this, and by providing us a chance to walk into the primary care practice and say, we will help you with your integration, we will help you with your psychotropic medications, and we will demonstrate it in a way that is efficacious for your patients, and then follow it through with evidence-based practice. The second finding that is very critical to developing a model is understanding that mentally ill die 25 years earlier than their peers, and this is primarily due to cardiovascular and metabolic disorders that are treatable. Patients with mental illness do not seek as much primary care as they should, and they're fearful of the judgment, and they're fearful of walking into the doctor's office. And that is something which I see every single day when I'm working in the primary care office, is when you see somebody who has elevated blood pressure and is bipolar, and you say, is it because of white coat syndrome? They say, I hate coming to the doctor. I avoid it like the plague. Yet they're severely depressed or they're severely manic, and they have some significant mental health issues. It's important to also address the cardiovascular and the metabolic disorders of patients with mental illness. And there's a lot of data on this, about smoking cessation. It's about data about the medications, the impact on their bodies, and the lack of monitoring in primary care, as well as psychiatric care. And we really do have to be responsible for our patient population. It's not just their mental health that we're responsible for, but as psychiatric nurse practitioners are further progressing our field, we are responsible for their medical care in increasing numbers. We can do a lot of physical assessment and refer them to the proper people. So it's very treatable if we really wrap it around. Now, since this finding has come out, I think it's been 20 years since the finding has come out, and the finding has not been significantly changed. The data is still the same. So we really haven't, in the past, even with the past healthcare system, haven't changed the way that we've handled some of our mentally ill. The next finding I wanted to discuss was 3 out of 10 patients with a medical disorder also have a mental health disorder. I was surprised that it was this low. I see a lot of patients that have medical disorders that, a lot of them do have more significant mental health disorders. 7 out of 10 people with mental illness have a medical illness, and I'm not surprised by this at all. This was actually more on key. Major depression is a risk factor for developing a medical condition, and the findings have found that a lot of it is because of pain and inflammation. Immobility, obesity, smoking, all impact on the ability for on a patient to manage their medical problems and have good health care. So it's very important to understand that. But there's other findings, and we have to, when we develop a vision, when we develop a model for integrated healthcare that's focused on nursing, focused on psychiatric nursing especially, we need to take into account that these statistics need to be identified and used to develop that program. And in the next slide, we talk about the fact that asthma, people with asthma are more likely to be diagnosed with depression. So by screening for depression on every asthma patient would be something that we would do. Primary care home is the perfect place for mental health because 70% of all primary care visits can be also have complications of psychosocial issues. And most primary care physicians are not equipped or lack the time to fully address the wide ranges of psychosocial issues that are presented by patients. And emergency rooms. My husband's an emergency physician, and his organization has described how over 50% of all patients that present in emergency departments, and I think that that is actually a low ball number, have a psychiatric complaint, mental health, or a substance abuse disorder. And nearly half of all cigarette consumption, which we know is tied to asthma, cancers, and other significant illnesses. Over half of the patients who have cigarette consumption also have behavioral health disorders. So we have some significant issues. And if we turn to pediatrics, pediatrics has a bigger impact. We actually could do a lot of good work with child and adolescent psychiatry by actually doing a pediatric integrated medical home, or addressing and assessing the pediatric need by targeting early intervention of developmental disabilities, of childhood somatization disorders, including obesity and headaches, of mood disorders, oppositional defiant disorder, bipolar disorder, attention deficit disorder, personality disorders, intensive mental health services to do early intervention for family system issues. But the reason why we need to do this is because of the 20% of all children exhibit symptoms of some form of mental illness, yet only 20% of those children actually receive treatment. Over 50% of all lifetime cases of substance abuse actually can be tracked back to age 14. Okay, and that's essentially true for mental health disorders. And 3/4 of patients with substance abuse disorders are seen by age 24. So early identification can be done in pediatric homes, and we do have a place there. And plus, there's a severe shortage of child and adolescent psychiatrists, and this puts more pressure on the pediatricians and the pediatric nurse practitioners to screen, diagnose, and prescribe for children and adolescents, even with very little knowledge. And they don't have the ability to do early intervention and psychotherapy, or know where to send patients to get the right help for the families to do more of a deeper assessment. And that is something which they're now being pressured just to medicate them, and that's not the first line of treatment recommended by the American Academy of Child and Adolescent Psychiatrists.
Okay, thank you for describing your vision for integrated care. We certainly need this type of care, and I think you've made a clear case for why children especially need this type of care. Could you now provide us with a firm look at what integrated health care actually is?
Oh, yes, that's good. We have to look at the fact that it really means systematic coordination of physical and behavioral health care. In a lot of the earlier definitions, it meant that you really did have to share the common space, the common vision, be integrated fully into the medical practice and be employed by them. And that's great in the clinic model with public health. But when you take it outside of public health and you take it into healthcare that is more your common healthcare in your communities, which is in your private medical practices and pediatric practices that take commercial insurance, it really doesn't necessarily have to be on site all the time. It just means that it has to have systematic coordination of physical and behavioral health care. And what that means is that you have to have access to psychiatric or behavioral health consultants, which means that you can be co-located with, like in my situation, we do have an office within their office. We actually have a wellness center, a little little room with a door, and we have a privacy ability. It's good enough size that we can actually do a psychiatric interview and do some brief psychotherapy and prescribe interventions and medication, a variety of things, and track and trend them. But it's co-located because some of that information is shared and some of that information is not. We still live in a two-silo world where my reimbursement comes from a commercial insurance, and it doesn't come from the same commercial branch that the primary care doctors get. So they can't really hire me and get reimbursed for me. That in the future might change with different models being proposed with reimbursement. But the key thing is that we also need to collaborate on patient care, which means that if a patient has migraines and they also have anxiety, well, is the anxiety causing the migraines? We have to work together in understanding what is appropriate to deal with that patient. And we do this every day, and this is what integration is about. Integrated mental health is about that bringing together and collaborating with the primary care provider, and it could be the nurse practitioner, on patient care. Okay, unified documentation is nice when possible. And the way that in an integrated mental health system, giving them information about how you saw the patient, what medication you've prescribed, your diagnostic criteria that the formulation of the problem and the diagnosis, and the interventions given. It doesn't have to give information that is confidential. It doesn't have to share substance abuse either. It has to be about what is critical to the care planning. Also, collaboration and integrated healthcare is about the education of the consumer regarding their health challenges, and what interventions were given, and what medication, and how that needs to get followed through also with the primary care providers. And that's truly the care coordination that's needed. Also, if we refer a patient for labs, or if we refer a patient for a sleep study because of insomnia, this is within our realm. This is our scope of practice. We can do whatever we need to do within our scope of practice, but the care coordination of making sure the patient goes for those services needs to also then get communicated back to the primary care team as well, so that they can reinforce it for us. And it's just a key to that process. The patient-centered medical home also defines integrated health care. And they define it a little bit differently because they talk about the reimbursement models and the benchmarks. And the insurance companies are incorporating meaningful use and measurable outcome parameters in integrated health care. So they are redefining it in terms of data collection and data expectations. And this is going to help us with the incentives, increasing our incentives for evaluation and medical and management codes. And with that, we're going to be able to handle a lot more cost effectively, so that we'll be able to afford EMR, we'll be able to afford care management and care coordination time and team building, not reflected in the dollars and cents that we have at this point, because that isn't covered. So that's really where we're going with as far as the integration, where it's been defined as far as the parameters of integration, and then it was defined a little bit more with the reimbursement of integration. Now, the data regarding patient medical home, there's a decrease. There's a lot of cost savings that we've been seeing in the data, and there is a data that just came out this month, January 2014, called the Patient-Centered Medical Homes Impact on Cost and Quality, and it's an annual update to the evidence that they've had before. But this reflects the 2012 and 2013 data. And in the past, they've seen that cost savings of 20% to 40% are not uncommonly reported in the design population. There's an increase in patient self-management. There's a reduction in use of unnecessary or avoidable services. There's an improvement in patient health indicators, an increase in preventative services, and there's improved quality and improved access, which then increases patient satisfaction. Patients become more involved in the patient-centered medical home, and they really do want to be involved. They want to be able to handle a lot more of their own care and understand what's expected of them. So that's a very important way of looking at our cost effectiveness. And therefore, once they demonstrate cost effectiveness, then we're going to be able to ask for what we need as far as a profession for our reimbursement. Now, there are many different models of integrated or collaborative care that have been demonstrated over the past 30 years. These models, they're available on SAMHSA's website, which you'll see at the end of this presentation, because they because SAMHSA has really been invested in making as much information about different models, and they actually have treatment. They actually have employee manuals. They have different kinds of things with different kinds of steps that you can take to implement integrated healthcare, and so they really have been proactive about that. Many of the models that have been written have involved psychiatric nurses in the development and implementation, and I take my hat off to the early pioneers, especially at Impact out in Washington State, and the Diamond model up in, I think it's Wisconsin. But there's a bunch of different models that are excellent. MacArthur Foundation screened for depression healthcare as well early on, and those are all available, and they provide a core of models that you can choose from that address the different complexity presented in different types of primary care involvement.
Can we talk a little bit about the levels of care that people will be requiring as they come into these integrated care facilities? Certainly, we're going to have different levels of acuity, and I wonder how these models will address those needs.
Yeah, you have to take a look at the levels. Not everybody wants, a full press of psychiatry, insisting that you take an antidepressant. The first thing that you have to do is you have to do preventative services and screening. And in primary care offices, they've been strongly encouraged for the last 20 years to do a PHQ-9. It's been revised a little bit. A lot of people are using the PHQ-SADS or some other psychometrics. Sometimes they just use a PHQ-2, which just asks 2 questions. PHQ is Patient Health Questionnaire. But that is something that the primary care doctors tend to ask 1 or 2 questions, and then they go on to the full 9 if they really want to do a full screening. And if they want to do anxiety screening, they use the SADS as well. And that really identifies different types of patients that and what they need to do, and also see if it actually interferes with their health care. Level 1, which is early intervention, so if they screen positively on the PHQ, then they do a brief assessment, and then people are supported for giving additional resources, given a name of an access to a mental health provider, or a warm handoff. Like what we do is we actually, if a primary care doctor actually sees that, okay, you seem to be depressed, let's have somebody do a further assessment. So our behavioral care manager, who in this case it isn't a BSN, it's a bachelor's level mental health provider, comes in and actually takes more of an intake, and that's usually done in the primary care office. Sometimes the primary care physician himself or herself does the brief assessment. It's not necessarily what they think they really love, but it takes away from their medical analysis, and it goes more into the mental health. But it does frequently lead, when the primary care physician or providers do the PHQ, it does lead to them offering a psychotropic medication, when in our realm we would be offering, let's talk about psychotherapy and get you in touch with the right provider to do the right assessment, and let's further where we're going. The level 2 is the specialty consultation and treatment and coordination. And this is for patients who have more immediate or somatic level of mental illness and require more psychiatric or behavioral interventions. And this might involve a more advanced evaluation of the cause as well, because not every depression is because of depressed mood. It could be because of labs. It could be like thyroid or diabetic control could be causing it. It could be because of another problem, a family cycle problem. But the end result would be leading to a treatment plan that would detail psychotherapeutic interventions, education, and psychiatric interventions. And sometimes that's when once we do a full evaluation or full consult, that's when we produce a consult note and a treatment plan and care coordination. So that's in level 2. Then we go to another level, which is level 3, which is more intensive mental health services for complex chronic problems. And this is usually done outside of the primary care environment. We usually refer a patient with higher complexity than what's just handled in a primary care office to a mental health provider. And that doesn't have to be my office. It can be somebody else's office down the street. It can be a hospital. It could be a psychiatric intensive outpatient. It could be something else. Or it could be to my collaborating psychiatrist to do a little bit more of an ongoing assessment of memory loss or whatever that's more acute. But this links patients to community-based psychiatry, and a lot of patients need that. There's community support groups for a variety of mental illnesses. In our area, we have a bipolar support group, and we like to link patients to that because it's free, or it's low cost. They give a donation, and they meet other people, and the same thing is true with AA, NA, CHAD, which is for attention deficit disorder, but there's other community-based services that we can actually refer people to. Plus, we can refer them to county support. We can refer them to the behavioral health evaluations for developmental disabilities, or the school districts, we can refer to them. Psychologists can do more of a learning-based and ADHD documentation that we don't have to do in the primary care environment or in the outpatient clinics that we run. The other thing about the third level is that we do care coordination between those resources, and we develop a treatment plan that doesn't necessarily tax their healthcare dollars, nor does it tax the primary care time. So that's something which is very, very key to cost effectiveness, and the providers of that really encourage that, and it's nice. And the higher levels than that would just be to refer to to triage into a psychiatric hospital, which I didn't even cover on this.
I certainly think you're sparking an interest in the audience about what integrated care can be. In order for us to really understand the principles involved here, I was wondering if you could talk a little bit about terms that people actually need to understand in order to fully grasp this model.
Yeah, I hope that people understand that they can do this model, that this is something which they can set up. You don't have to ask permission. You can set this up. We can talk about how that works later. Even we can do this online through the member bridge. But there are key principles that you need to understand. Okay? The first principle is that it's always family-focused. We've changed the focus now. We've changed it from individual behind closed doors, acting as if it's only them. Mental illness affects everybody. You never see the patient necessarily as alone in this world. And you need to see what environment, what family they can actually call upon to help them manage their own care. The second thing is professional collaboration. We work with other professionals all the time. We have to identify that collaborative team. And that collaborative team might be in the primary care offices, or it might be distant. It might be that they go to a specialist somewhere else, an endocrinologist, or a rheumatologist, or even they go to AA. And that's professional collaboration. The third thing is that we really have to go back to our old basic psychiatric nursing, in which we actually do care plans, okay? Because that really is the backbone of our profession, of nursing. And we have gotten away from that into more of a psychosocial and psychologist-based program. But the key principle that comes back out time and time again, and this comes from resources out there, they're trying to tell even psychologists, you need to develop a care plan. And then you have to also then make sure that the care that you suggest is then followed through with care coordination. And then don't forget to educate the patient. A lot of patients need to understand their side effects of their medications, so that they know when to call you, or they also need to make sure that they get additional monitoring. We have a lot of patients who are on mood stabilizers that need consistent monitoring, and some of the atypical antipsychotics especially have to get monitored for some of the more significant side effects and with blood chemistry that are invisible. And this is how we prevent the mentally ill from dying 25 years younger than their peers. So that's really part of it.
One point that you made that I thought was quite interesting is that psychiatric nurses, or nursing in general, we don't have to ask permission to do this and become part of this model. Could you address a little bit more about how we can take our place in the integrated healthcare model?
We have to understand that the Affordable Care Act gave us a lot of permission to expand our role, expand our model of care within integrated health care. And it didn't eliminate the insurance companies or Medicare or Medicaid. It didn't provide one payer system. But we have a ability, because the Future of Nursing document and the LACE making it a little bit more consistent in our education, and our roles are more defined and evolving towards more legislation, that psychiatric nurses actually can open up a practice. And we can then, apply for status within an insurance company as a company that then would do integrated mental health. I did this 18 years ago when we didn't have these laws. And that was primarily because I was, at that point, a clinical nurse specialist, and clinical nurse specialist legislation really reflected, our role reflected more of an independent and autonomous role. And nowhere in the legislation that we investigated it for many years, nowhere did it say that I had to work for a physician. And that hasn't come up at all. And I would know this because of some of the work I do with Magellan's Provider Review Committee. We have the ability to open practices and employ other clinicians underneath us. In some states, we are limited to have independent contractors underneath us, especially psychiatrists. Psychiatrists in some states can't work for nurses. But psychiatric nursing has the opportunity to demonstrate our full scope of practice if we can organize and advocate a consistent and clear message, and not to legislators, but to the insurance companies. And we do get Medicare, but we don't get Medicaid. In many states, Medicaid is limited to nonprofit funding or other smaller caveats of the laws that limit our scope. But in most cases, you just work for a clinic group, and that's the way you get around it. You work for somebody to get that, or work for a foundation that's nonprofit, and then you can get Medicaid. But we do have a clear pathway that we can now investigate about opening practices and actually employing independent contractors to go into integrated settings. It doesn't have to be you; it can be other people. We also have we also know that healthcare is now evolving, and if we can use this opportunity to update and deliver new models, it can be more effective in that are more effective in mental health impact on medical issues. We'll get a lot further. So by evolving our healthcare, by using models, I think that we'll be able to get something much larger in the future. Mindful care is a model that I developed. I presented at APNA conference, and you're certainly welcome to go back. It's available on podcast and listen to it. But the key thing about mindful care is the fact that I decided 5 years ago that we needed to demonstrate how medical and mental health interact, and that how we assessed a patient is one way, and we needed to provide a whole person assessment, not just a mental health assessment. And in the medical aspect of it, which is the M, medical and mental health, two sides of the brain, two sides of an issue. The medical and the mental health are co-occurring issues, and we need to show their diagnosis and also the impact on each other, how they impact, and then how it impacts on the identity of the patient, how in the context of who they are and how they function, and how the medical or the mental health illness then affects function in the family, function at work, function in their sexuality, in their sleep, variety of identity. But the key piece of this is nutrition. Nutrition and exercise are the key to health promotion programs for persons with serious mental illness. There's a document that came out last year from SAMHSA that had a summary that was really very dramatic. It said that obesity and sedentary behavior are major risk factors for cardiovascular disease, diabetes, and reduced life expectancy. And over 42% of adults with serious mental illness are obese. Fewer than 20% of people with schizophrenia engage in regular moderate exercise, and people with schizophrenia consume fewer fruits and vegetables and more calories and saturated fats than the general population. Now, just those two statements illustrate that nutrition is key to managing the whole brain and understanding how people work. Now, other studies have shown that vitamin levels contribute to depression and other mental illnesses, and insomnia with melatonin levels. People need to readjust their sleep cycles. So there's a lot of different things that we now know that are psychiatric nursing interventions that we now can use, and that's incorporated in this. Another key point of this is the developmental age and stage related to the stage of life that the patient's in. So not everybody who is 18 functions like an 18-year-old. There's a lot of developmental growth, retardation, or advancement, depending on who they are, and that doesn't advance. And also this pays attention to our child and adolescent population as well as our geriatric population about what's appropriate as far as their memory is concerned or their attention span and how to function. And the family system, the unconscious, and the level of functioning is primarily our assessment. So if you break this down again to just do the mind care, it actually is much more congruent with what we can use in primary care, and that's part of it. And the second part of the mindful care model that I put together years ago was the care planning process. And this reflects in the patient-centered medical home principles that I already addressed, is collaboration. You're never treating the patient alone, that there's always the other primary care or providers in the system or the family that you need to collaborate with, and you need to have a clear planning of it, and that is communicated across. The second piece of the care planning process is teaching adaptation skills. Then that's psychotherapy, as well as stress management skills, anxiety reduction skills, even about how to handle themselves socially in that psychotherapeutic skills. The third part of that is recovery. The recovery model is very important, installation of hope, also teaching them that even if you relapse from mental illness or any other illness, it's okay to come back and talk about it. It's okay to get back into treatment. The brain recovers differently than alcoholics or substance abusers. It's not a definitive recovery, and the levels of recovery might not be a complete brain change, but actually is a process that we actually instill hope and understanding that, yes, we can stabilize, but stressors do trigger them. And the last part of the care planning process is the education, and we talked a little bit about this earlier, and that's really the patient understanding their illness, understanding psychiatric medications, understanding resources and management skills, and that's really a key thing that fits right into what the patient-centered medical home model really values, and this provides it in a very clear way. So that's the model that I worked with, and this was developed years ago with with discussions with some of my colleagues, especially Nancy Hanrahan, who really worked with me originally on this model and really listened to me about where this was going and how this was really going to be fleshed out. And I've never really researched it at this point, but it's a relatively good model to follow at this point. We'll advance that in the future.
Well, thank you so much for sharing your model of mindful care. As we proceed with the development of this role of integrated care for psychiatric nurses, I'm certain that research will be done and theories will evolve that will support the work that we're doing. I'm curious what your thoughts are on how we're doing in terms of developing a workforce to take their place in this model. Could you please address that?
Well, we have developed the workforce with advanced practice psychiatric nurses. The clinical nurse specialist as well as the nurse practitioner both have extremely good training and scope of practice that is very good for the primary care environment. And we really have to continue developing it further, especially in enforcing about the fact that we do look at the whole person. There are changes in the mental health approach in the community. It's much more focused on prescribing and not psychotherapy. So a lot of our professional colleagues who are just psychotherapists might feel left out. But there is some very important places for it. One area I do want to bring up is that psychiatric mental health registered nurses, and these are primarily RNs with associate's degrees as well as BSNs. And these are generalists. We need to get out of the hospitals. There's much more to be done in the communities than just the hospital work that we've been doing. And behavioral care managers have been used across the country in demonstration models as providing early assessment, behavioral intervention, psychiatric triage in primary care. And I firmly believe that if it was up to me, I would have a psychiatric BSN in my office right now. But unfortunately, the reimbursement is not it's not a funded position. Even though they're licensed and they're able to provide and their scope of practice exists, the insurance companies don't recognize them in mental health. They might, in the medical side, acknowledge the fact that RNs and BSNs have a purpose in healthcare management, but they do not on the behavioral side. And that's something which even this morning I was able to write an email saying, is there any funding for a BSN? It's very, very key to the future of understanding that. And one of the things that I want to bring up is what a psychiatric care manager actually does, because then you would be able to see that this is a firm place for our graduates and to perpetuate our profession. Psychiatric care managers consistently monitor psychometric scales for patient and mental health, understanding what the mental health symptoms are so that they can be reflected in the assessment. They also monitor the BMI, the blood pressure, the waist circumference, and the weight, and calculate that in a consistent way so we can track and trend whether or not a patient has some effects of some of the medications that are prescribed or have some obesity issues that might be causing the mental illnesses or other parameters. They also can ensure that the lab values are done and charted consistently, and that's for the CBC, the metabolic panel, thyroid, vitamin levels, and psychotropic blood levels, making sure that they're done consistently. And they also can make sure that EKGs are done for QT irregularities to make sure that patients aren't given medication that actually can cause heart attacks in that individual. And also do EKGs for patients who are taking psychostimulants so that ADHD does not cause irregular heartbeats. And also they can witness the urine drug screen since nobody else wants to witness them. In addition, they also can refer to other mental health professionals for psychotherapy in groups, and also the community-based services that I described earlier. A lot of bachelor's level psychiatric nurses do smoking cessation groups, and they're excellent at providing the medical as well as the psychological support and interventions that are desperately needed in that population. They also can collect data regarding how a patient's doing and show overall outcome studies. They can coordinate the care with the primary care doctors in more complex cases so that the advanced practice nurse can actually do the psychiatric assessment and move on and know that at a certain date and time we'll get back together. They can actually coordinate the appointments for the complex cases. And they can also provide injections for naltrexone and atypical antipsychotics, and do triage of acute cases so that we spend our time with the right psychiatric consults, the people that are needed.
Okay, thank you. I have a comment to make there. I think it's really important, the point that you make about registered nurses need to think of different ways to work, particularly outside of the hospital. And I don't think that we tend to consider registered nurses in the integrated care models and integrated care settings. One area that has been explored in some depth is that as advanced practice nurses getting out there and being part of this integrated care. Could you address that?
The advanced practice nurse does a little bit different. They do a higher level than what the bachelor's level or the RN level of care manager. They provide psychiatric and substance abuse assessments and treatment. They order and evaluate lab studies and EKGs. They develop care plans for the whole team. They address co-occurring symptoms and management to improve outcomes. And they monitor mental health symptoms and long-term impact on medical problems. This will cut down on some of the medical impact of mental health on the whole person. The advanced practitioner also screens and does brief counseling for substance abuse and prescription abuse. And that helps the primary care have a second side to something, saying, okay, I've noticed you use too much of your prescription medication. Let's screen. Let's go talk to somebody, and let's see what we can do to work together to make sure you get the proper amount of pain medication, and you realize that there's other ways of coping. Advanced practice nurses also coordinate with the team and with outside mental health and behavioral providers and hospitals to make sure that information is passed along between the other levels of service that are available.
So you said you started in this type of practice 18 years ago. I'm sure you've seen some roadblocks that you've had to get over in the course of your career. Could you share some of the barriers to becoming involved in integrated care?
Yeah, it's funny. When I first sat down with this primary care practice that I work with, it's North Willow Grove Family Medicine. They said to me, I said, do we get any brownie points for saving all your literature for all the years that you came to us and say, can we do this? Are we ready for integrated mental health, or can we do collaborative care? And they pulled out old brochures and old files that I had sent to them about how to refer to me and how to integrate me into their practice. So the key thing I have to address the fact that reimbursement prevented me from working in other settings outside of an office. My setting was only that address that I was allowed to work in. I wasn't allowed to work in alternative settings. When I contract with the insurance companies, they say, we need to make sure we inspect your site. We need to make sure that certain things are met as far as documentation and safety of documentation. So the credentialing process actually was, at that point in time, very rigid about making sure that I practiced only where they allowed me to. So the place of work had to change, and then that affected my ability to reimburse. The reimbursement codes were bad. They only said that I'd be able to reimburse for, and they still do this now, many of the companies say, we will only reimburse you for a psychiatric evaluation or psychotherapy codes and not these behavioral health codes. Behavioral health codes reimburse at a much less quality than my E&M codes that I'm now able to use as an APRN in these settings. Reimbursement is still not congruent, and it still remains a barrier, and I do not get what my cohorts do, my NP cohorts do in the primary care environment. So reimbursement systems are still a major problem with getting to moving on to the better place for making sure that this is more cost effective. So we have that as a major barrier, and we're getting closer to moving on beyond that. But because they're also talking about other kinds of reimbursement, other models of reimbursement, and making sure that the consultation time can also then get reimbursed. So there's a call for a change from a fee-for-service system to a capitated contracts, or to even purchase of services, which is a different kind of funding, which I won't go into at this point. But there's different types of funding that they're looking at, and most psychologists are really looking at this first and foremost more than us. And one of the problems with, as I mentioned, with the BSNs have not been able to get reimbursed at all, and they certainly can't provide independent care that an APRN, most of us can. But the BSNs do not get reimbursed at all, even though they're licensed. Or any of the other master's level, bachelor's level healthcare professionals aren't getting reimbursed for their care either. So that's really a key thing that has to get addressed. We have to demonstrate more that we are cost effective in order to make these changes, and then we have to do more research about that and see what would be better as far as which direction we're going in. The second barrier is a reduction in workforce. And we're noticing that psychiatrists are aging out. So the shrinks are shrinking, and they're not replacing themselves. And as much as we still need them, and we're not trying to replace them, and they're dwindling. Okay, and it's very distressing because we need them for collaboration agreements, and we need them for higher levels of care that we don't provide or have yet to provide. We would rather refer for certain things, like ECT. And so we're facing the psychiatrist aging out. We also have major changes in increased demand. When you provide mental health in primary care offices, you will notice that there is a huge demand for your services, and then you won't have enough time to do anything. And there's increased documentation needs, and a lot of people don't want to do that. So that there's dissatisfaction with the profession. There's a lot of things that we have to understand as far as the new nomenclature and the codes, and we're also aging out. So, making changes are going to be very difficult. And the third point is, well, APRNs lack public and professional awareness. We're not doing ourselves any service unless we get out there and have a voice and demonstrate that advanced practice nurses there is a psychiatric mental health advanced practice nurse. And creating that awareness will also then allow us to campaign for better reimbursement, campaign for other things. Other psychiatric nurses do not even see the option. A lot of the advanced practice degrees, and we are invisible in many of their communities. So we really need to be able to be more populated. The cost of education for the psych CNS to go back and get the extra classes is still high. A lot of us were intimidated by that climb to the next step with the LACE proposed, and we do need the educational funding because a lot of us could not go back to school. So we really need to say that if you want to increase psychiatry penetration in our communities, please look at your clinical nurse specialists going back to school for those extra classes so that they can become your next providers. It's a lot shorter than psychologists gaining that knowledge or anybody else. So taking a look at the role that we can play in advocating for grants for psychiatric nurses. The next area that I encountered as far as a barrier is collaboration agreements with psychiatry. And this is something which I'm sure that a lot of us talk about, but we don't necessarily publish anything about it or deal with it, but it's been on the member bridge a lot. Most states require supervision or collaboration agreements between psychiatrists and psychiatric nurse practitioners. And the psychiatrists in general are less than enthusiastic to become our collaborating psychiatrists because they see their liability as being increased when it actually decreases their liability because it provides better level of care, and in working in a team, it actually provides more access. So, they don't understand that, and they still are stuck on their safety issues when we actually have demonstrated that our safety is pretty insured, and we have professional standards as well. We need a clear statement about this. We need a statement from our legal resources. I was able to provide some statements to the collaborating psychiatrists to get good collaboration agreements in place. I was able to demonstrate my skills to the primary care, my collaborating psychiatrists in a variety of ways. But not everybody who I hired as an NP to work with me was able to demonstrate that. So it's very important that the trust be demonstrated before a doctor signs on as a collaborating psychiatrist. And then we have to make more of a statement about what we need to do as far as how to collaborate. And I think that was a barrier that I had in expanding. And this is something the Institute of Medicine identified as one of the barriers. So the last barrier to practice has to do with the Medicaid and the federal employees contracts. And this is something I brought up earlier. Most states have the federal employee contracts deleting us. They only cover psychologists, psychiatrists, and maybe social workers, depending on which state or what contract it is. They don't include psychiatric nurses as independent credential providers. And this is also true with Medicaid. And that's why we don't have Medicaid contracts as independent providers. So we have to go through other foundations and work underneath somebody for a Medicaid contract. What are they afraid of? They don't reimburse that much. It's not like we're going to steal the bank. Providing, a lot of these are block grants that they want to make sure they go to nonprofit funds. We can own a nonprofit. So, it is limiting. And I think that that's the last barrier to practice that I can think of, and that was identified by the Institute of Medicine. So that was key.
Okay, thank you for sharing your thoughts about barriers to nurses taking their role in an integrated care model. I think as the Affordable Care Act is rolled out and we revolutionize healthcare in the United States, I'm saying that hopefully, we'll have more and more support for the work of registered nurses and advanced practice registered nurses, especially in psychiatric nursing. Could you talk a little bit about the supports that we have for developing a practice such as yours?
Yes, that's very key. We were best at supporting each other. Okay, the number one support that I received throughout the whole 25 years that I've worked in psychiatric nursing, 29 years of working in psychiatric nursing, was other psychiatric advanced practice nurses talking to me, encouraging each other through a variety of things. It was through these connections with other psychiatric nurses that I was able to then perpetuate the process that I was in, pursuing integrated mental health and collaborative care. And without the organization of American Psychiatric Nursing Association and other organizations, I never would have continued that pursuit. Even presenting on a state or national level, it actually continues the conversation, even though we were blocked on a commercial side. It also encouraged people who are continuing to work on the clinic side, the federal qualified healthcare clinics, to understand what the vision was from other providers that weren't necessarily actively working in it, but knew a lot more about how to do it. I couldn't go backwards and go into a federal qualified healthcare center because I had my own practice and I wasn't going to go there. I couldn't. But I was able to share that knowledge, and that perpetuated our ability to say that we were in that field. I also want to briefly mention there are significant people that helped provide that support. Nancy Hanrahan, who's a professor of nursing over at Penn, University of Pennsylvania, she did a lot of research about the workforce development and healthcare implementation and models of healthcare, and my conversations with her were probably the most progressive conversations that perpetuated into developing the mindful care model. Gail Stern, who was one of our board members until this past year, she was an executive director of a Department of Psychiatry that was developing a hospital-based integrated healthcare center practice. And she employed psychiatric nurses and was able to share knowledge over the years and her obstacles as well as what they were doing to help perpetuate this. And the last person who really perpetuated it was Nick Croce, and he dedicated his knowledge of connections of key people and how we could mentor each other through the process. And without him, other executive directors couldn't have done that. But without him remembering who did what and connecting the dots and connecting the people, and also incorporating a member bridge, we never would have been able to connect. So I think that APNA really deserves a lot of credit for this process. Insurance companies were blocking this. They actually had to work within their own parameters. And actually, 2 major insurance companies reached out to me over the years consistently, and that was Aetna as well as Magellan, to try to help perpetuate this to a higher level, but they also blocked it because they said, well, you can't go any further. We can't change everything overnight. We will have to wait until next year. Put it back on the shelf. We'll get back to it. So they did help in some ways, but they also saw where their obstacles were within their companies, and they really did try, but they really couldn't help me much further than that. But in general, the other organizations that do help support other people and bring together multidisciplines of mental health providers. One is the Collaborative Family Healthcare Association, and I became involved with them at the very beginning, and Margaret Catronio, one of our psychiatric nursing professor that I knew, was one of the founding members, and they've always incorporated nursing into their vision and encouraged nurses to be involved. The next organization that really perpetuates healthcare is the National Council of Behavioral Health, and we need a voice in this company. I need to make sure that I don't know who is in there that works with it, but that's the key place where healthcare policy is developed, and they were the voice that was behind what was adapted in the Affordability Care Act. And the last organization that I take my hat off to, and I encourage everyone to visit this website, is SAMHSA. SAMHSA put together a perfect website that will be a great resource to anybody who wants to develop integrated healthcare. And it addresses all the models, all the solutions that have been out there, all the white papers that have been developed. They're published on that website, and multiple different layers of training and webinars and other things that are available, and that is a great resource for everyone.
Okay. Excellent. Thanks so much for sharing those resources with us. I highly encourage people to, if you're a psychiatric nurse, become involved in the American Psychiatric Nurses Association. If you're not a psychiatric nurse, your professional organization is a great place to start if you're interested in hanging out a shingle or setting up a practice similar to what Sharon has done. As we conclude this policy forum, I wonder, Sharon, if you've got some comments regarding the future direction of integrated care.
Well, I think we have to start the conversation. We are part of this. I think by having this webinar, we are starting the conversation. I think we need to find and share grant opportunities and funding strategies for development of a workforce, and demonstration grants and other kinds of grants that are available, so that we can not necessarily compete with each other, but so that we can join together and do a national demonstration of other kinds of models that are out there, and demonstrate and talk about our role. And I think that that would be welcome. I also think that we should develop position statements. I put out there about the BSN, or the Associate's Degree Psychiatric Nurse. They're licensed professionals, but they have a valuable role in monitoring and patient education and delivery of integrated healthcare services, but they're not reflected in the roles that are currently available. And I also think that we need to develop policy statements, which we have already in some ways, about the integrated healthcare role of the advanced practice nurse, but we also need to update a lot of the things to include lifespan and our holistic ability to use vitamins as well as psychotherapeutic interventions. I think that that direction is very important. I also think we have to join, as an organization, join the National Council of Behavioral Health and participate in conversations about reimbursement and policy reform, and identify clinicians within APNA that have that involvement and continue to connect us, so that we have more of a council of integrated healthcare. So we discuss what we can do as a group of people, share ideas, share directions. I also think that we need to look at what we do in chronic medical conditions and actually discuss psychotherapeutic nursing techniques, both holistic as well as psychotherapeutic and psychopharmacology. And I just want to put out some examples: diabetes management, depression management, and how diabetes and cardiovascular and chronic pain impacts patient coping with depression, with their illness, with a variety of family issues. I also think that we should address anxiety and how it's displayed in irritable bowel syndrome, somatic obsessions, migraines and headaches, among others, obsessive tendencies. And finally, I think that we need to take a look at our momentum. I think we need to use what we have, or we will lose it. We are a small profession in comparison to other nursing professions. If we don't stand up and become psychiatric nurses in a public domain, they will only see us as being inpatient hospital, and we will lose what momentum we possibly can capitalize on that have been demonstrated through the future of nursing. We now have the ACA as a law. People can't change that very easily. They've tried. We need to demonstrate it to keep it viable. We need to use nursing as a role that we play, that we actually function in. And unless we demonstrate the process of psychiatric nursing in our own committees, we will be invisible. And I think that's my main purpose is, in my community, is not to be invisible. And I'm not. So that's where I have to stay.
Well, thank you so much, Sharon. I've heard so much about you, and I certainly know that you are not invisible, and quite visible in your community and in psychiatric nursing. I know you've got a busy practice, and this was time hopefully well spent for you, and
Yes.
I certainly believe that it was for us. I expect someday you'll hear from someone that listened to this webinar or saw this webinar, and they'll say, I started my practice because of your presentation. I believe that that will certainly happen. The policy forum that was presented today will hopefully be a regular feature of the American Psychiatric Nurses Association, and we look forward to future presentations. Again, thank you so much for your time today, Sharon.